Welcome back to EM Note Journal Club. I'm James Carter, and today we're diving into a clinical topic that's highly relevant for anyone managing rapid atrial fibrillation in the emergency setting. Our focus, the potential role of intravenous calcium in preventing diltiazem-induced hypotension. Let's set the stage. You've got a patient with atrial fibrillation or flutter, heart rate over 120 beats per minute, and you're planning to give IV diltiazem for rate control. A familiar scenario. But as we all know, one of the common concerns with diltiazem, especially when pushed rapidly, is hypotension. So, could pre-treating with IV calcium help mitigate that drop in blood pressure? That's exactly what a recent randomized controlled trial published in the American Journal of Emergency Medicine explored. The study, conducted at a single center, evaluated adult patients with Afib or Aflutter and a heart rate greater than 120. These patients were randomized into 3 groups. 2 groups received IV calcium chloride before diltiazem. One received 90 milligrams and the other 180 milligrams. The control group received an IV normal saline placebo before diltiazem. Let's talk outcomes. The key measurement was systolic blood pressure at 5, 10, and 15 minutes after diltiazem administration. At the 5-minute mark, systolic BP was significantly lower in the control group compared to both calcium groups. By 10 minutes, the 180 milligram calcium group had significantly higher systolic BP than both the control and 90 milligram groups. And at 15 minutes, both calcium groups had higher systolic BP compared to the control. Heart rate reduction was also examined. Interestingly, by 10 and 15 minutes, the 180 milligram calcium group had a significantly higher heart rate than the other groups, suggesting a possible trade-off in rate control effectiveness. But before we jump to conclusions, let's consider the study's limitations. First, while the blood pressure differences were statistically significant, they weren't necessarily clinically significant. All groups maintained a systolic BP above 115 mHg throughout, and there were no differences in hypotensive rates requiring intervention. Second, the method of diltiazem administration may not reflect typical clinical practice. The study used a rapid push dosing of 0.25 milligrams per kilogram IV diltiazem, which likely exaggerated the hypotensive effect. Most of us administer diltiazem more slowly, often over 15 to 20 minutes, which may reduce the risk of hypotension in the first place. Another important consideration, the use of calcium chloride. While effective, it's a caustic agent with potential for serious tissue damage if extravasation occurs. This trial wasn't powered to detect rare but serious complications like necrosis. In practice, calcium gluconate is generally preferred for IV administration due to a better safety profile. So, what's the bottom line for us as emergency and critical care providers? The results of this trial do not demonstrate a clinically significant benefit of calcium pretreatment in preventing hypotension following diltiazem. At this time, routine administration of calcium, particularly calcium chloride, cannot be recommended based on current evidence. However, there may be a role for calcium gluconate in selected patients, such as those who are borderline hypotensive or at high risk of decompensation. In summary, this study adds a valuable piece to the puzzle but doesn't change standard practice. Further evidence is needed before we can justify calcium pretreatment as a routine part of Afib management with diltiazem. That's it for today's episode of EM Note Journal Club. I'm James Carter. Thanks for listening. Stay sharp, and I'll see you in the next one.